Hi there, my name is Chris. Some of you may know me from other videos, but I'm here because I had the privilege to kind of give you my own 2 cents about the medical marriage family therapy model and provide some of my own experience with being in the setting and also being just around the model itself. And I want to be very clear on the get-go. I was in your shoes not too long ago, learning about this model, learning about what it contained, and it kind of was a mystery to me, to be honest. Started doing psychotherapy, started doing traditional, in what the traditional sense of therapy is, and then just happened to stumble across this MedMFT, and I was like, does this mean that we can integrate the medical field and also psychotherapy traditional? And to some degree, yes. The only caveat to that is you're going to be working within teams. So it is kind of a mysterious piece. And it's really important to know that this is an entity within itself. So knowing that going into it, knowing that it is a very different scope per se. Just be aware of that. But anyway, so to kind of get the ball rolling, I do want to kind of first of all talk about kind of the premise of what MedMFT is. And I want to start off by making very clear that, medical marriage family therapy, also called medical marriage family therapy IPC, so that's the integrated primary care model. I want to be very clear that we may use a lot of interventions. These interventions may be joining with the client, joining with the family, maybe using motivational interviewing, maybe using CBT, maybe using EFT, structural family therapy, all these different therapies which have been used. But I want to stray away from the idea that it's just purely based on interventions. Like the reason why this was created is down to kind of the theory-based approach that we wanted to move away, necessarily just focus on the medical model of this is just psychophysio or physio-psycho-social, all these different other approaches that prioritize the medical belief, the biological component. MedMFT was kind of established to kind of bring some of that humanism back into the approach what we work with our families. Not that it was lost. I think it was just we realized the research out there was saying that having that integration back in would be helpful. So I want to make that very clear that that MedMFT IPC model is. It focuses like it goes off kind of what Doherty and colleagues, they have their 5 or now 6 levels of integrated care, and that kind of goes up from working single alone, working in your own environment, not having any connection with a therapist or another doctor. And then eventually working within a setting that maybe collaborates with a primary care provider or doctor. And then on the complete end of the spectrum, you're working 24 hours a day, 7 days a week in the same building as that clinician. So the idea was that there's no loss of contact. There's no words lost in translation, right? So from, your family may see the clinician or the physician, and then right away we'll see you, the behavioral health provider, the psychologist, and basically integrate them both together. So this is where the foundation of this model was born, that we wanted to kind of provide a one-stop shop for services, so things won't get lost in translation or lost in general. So noticing that and going in with that mindset that we are bringing this humanism back. We are providing a resource to families who may have been overlooked, may have been not given the appropriate treatment in the past because it was just primary medical focus. So if you can go with that focus, you're in a good place. I know that's where I'm at in terms of my stance working within the clinics and hospitals where I work, and that's kind of expected. So, but you also got to think about, the 4 peaks model as well, where we talk about finance, clinical, supervision, training, operations. So when you become more of a MedMFT, there's all 5 things you're going to be thinking about, right? Is my client, we've got to think about the clinical side. Okay, clinically, is this going to work? Operationally, how are we logistically going to do this? Financially, can my clients pay for it, or will my agency or hospital be able to pay for this? And then the training, where's my supervisor at? Do I have an appropriate supervisor for it? And overall, if you look into research, I mean, the model, the whole model needs more research, but that's also something that you may want to look into too. With that being said, those are the kind of foundations. So the second part is about my own experience with this model. So kind of like what's already discussed with the different frameworks, my normal day as a MedMFT is I would, I'm very clear, I work in a more hospital clinical setting. I have a bunch of people around me who are also clinicians, either medical social workers, marriage family therapists. We have an on-site psychiatrist. We have a team of, we're not in the main bit, but we can get them to a hospital like nurses, for example, as well. A lot of people may not have that resource. And I want you to be very clear, just because you don't have those doesn't mean that you can't use the medical management, the MedMFT approach, right? Because again, it goes back to the theory of it. This is what we are doing to provide the care. It's not so much always the resources we have. The 5 layers, right? Five layers of integrated care. So, I would come into the office, make sure I do my work, or follow up any notes that have been missed, follow up any phone calls that have been missed. And then usually when I get right there, is that I'm collaborating with other physicians, you're collaborating with other nurses, you're collaborating with other social workers. Maybe, for example, if you're working with a kid one day, you go talk to the school. You're going to be sending emails, collaborating with them. You need to talk to a physician about medications, psychotropic medications. You're going to be emailing them or sending them a secure email, either through your system, wherever your clinic works. And usually that could take an hour, 2 hours or so. The key thing is you're collaborating. You're constantly going to be collaborating with other people. So you've got to be willing to do that. We often will also have treatment teams. So when our teams all come together and talk about the cases, we'll sit in, a psychiatrist, or we'll sit in, they're going to be reviewing about the medical side, biological side. We also have maybe the physician sit in. We have a case manager. We have a SUDS, substance abuse counselor. You're going to have a whole team. It's like an army, right? You're going to have an army of people working here. So you've got to be also able to hear your cases. There may be times when and it is humbling. I know there's a couple of times of me where it's been humbling, where people have come to me and said, that's not a very good approach, Chris. And it's in my own sense that, okay, I understand. What's the feedback? Here's the feedback. Okay, I'm going to run with that now. So being in a team, you've got to be able to, willing to accept that there's going to be criticism sometimes, or pushback. So that's a big piece. So once all the treatment teams are done, once you've done all the collaboration with all the providers, you're going to be seeing clients, right? Families coming in. So it always starts off with introduction, right? You may be looking over notes from previous other clinicians, previous other therapists. You're going to be kind of writing out what we have like a behavioral health assessment. MedMFT is going to use a lot of assessments because you want to get a whole picture of the family, right? So the BHA, what we would call, it's going to talk about, well, it goes back to the biopsychosocial spiritual model, right? You're literally using this assessment to assess the biopsychosocial spiritual model. Biological, psychological, social, spiritual. You're going to be doing probably an hour to 2 hours of this. Speaking with the family, speaking with the kiddo, getting to know them, using different interventions. But again, the core piece here, you want to get kind of try and get as best all the aspects. So you may do that a couple sessions. Then eventually you're going to start, once you've done the assessment, the key piece, you're going to kind of explain to yourself, what's the reason for my visit, right? So you're going to, as a MedMFT, you're going to sit down and explain confidentiality. You're going to explain what your role is in the organization. You're going to explain that you're working as a team, right? You're going to have a psychiatrist. You're going to have other people reviewing this and having them sign that off, because other families don't even will not know what MedMFT is, let alone some people not even having therapy before. So it's really important to really discuss your role and also what the focus is. Once you've all covered that, you've gone over safety assessments, make sure that they're safe. You're then going to jump into the intervention piece. So what is your intervention for that day? Could be working on communication, could be working on bridging that gap between the medical and the psychological piece, acceptance. As you both know, you're clinicians now, you're being trained and you're working on that. So use whatever modality works for you with this. And that's the beauty. You can use different modalities here, preferably evidence-based. But, I've used EFT, I've used narrative, I've used mindfulness, I've used ACT, I've used CBT, I've used a lot of different processes. But again, it's just making sure that you stick within the frame of what you're doing. And then this is the core piece of what MedMFT is, that you've done all that. Now you're going to relay that back to your team. So you've done the assessment, you do a quick email, you send a little note to the physician they're attached to the case manager they're attached to the SUD they're attached to, school. You're going to be collaborating. It's a big collaboration. So again, if you're not, you've got to be very honest with yourself. If I want to sit and have a private practice and not necessarily deal with all that collaboration, MedMFT is likely not going to be for you. You've got to be willing to collaborate, and also the setting. So ask yourself that very question. Do I want to do private practice? Which there's nothing wrong with that. I know 90% of the people I know, and I'm often on the fence too. If that's what you want to do, it makes medical family therapy from that perspective a little bit more difficult. So just be honest. That piece. So that, long story short, of all those 5, you're gonna introduce yourself. You're gonna give your reason for visit. You're gonna do the intervention you want to practice on, and then you're gonna collaborate with everyone out there or with all your team. So that's kind of what, after my clients, and then I go and obviously do the notes and write it up. So that's kind of what you would do in a medical family therapy situation. The other piece is you're going to be doing a lot of, if you do choose to do research, if you do choose to do your own supervision, make sure that is kind of appropriate and is getting to what you need as both as a person and also as a clinician. So there's a lot of options going into MedMFT. There is. Just know and just make sure what is a fit for you. So brief summarize of what my experience has been with the MedMFT model is number 1, stick with the theory. What was the underpinnings that Doherty and Peaks and all those different other medical family therapists were trying to find? It's not so much intervention based. 2, know about the framework. So introduction, reason for visit, background, kind of why we're here, safety assessment, then you're doing intervention, and then you're finally going to do the collaboration with your whole team. Number 3, you've got to ask yourself these core questions, right? And if anything you remember from this is the core question is, 1, are you wanting to do private, or are you willing to kind of collaborate? Because that's going to make a big difference here. 2, the settings. You're going to likely need a setting where you have medical providers and an integrated primary care team. You can still do the model, it's just going to be very difficult, and it's going to be harder. Number 3 is that also be willing to accept there's going to be a lot of changes. The medical system and the system in general, policies, new rules, legal requirements. You're going to meet a lot of things where you're going to have to approach a lot of those things. So be aware that you're going to have a lot of social changes and clinical changes. And then lastly, know that these sessions can be difficult. You may have a cancer patient one day, you may have one going through grief, you may have one coming in for suicide ideation, you may come self-harm. You're going to have a myriad of different clinics and practices. So you've got to be really willing to put that hat on. You're going to have a lot of different hats. You're going to have your therapist hat and your personal hat. And the self-care is so important, because burnout is real. And especially in this fast-paced, ever-changing, collaborative approach, you kind of got to be ready for that. So I hope that was helpful. Again, if you ever have any questions, concerns, please reach out to me. And I wish you all the best in your studies. And if this is something that inspires you, just do some more research, look into it. I wish you all the best. Have a good one.